This Thursday, we thought we'll discuss about the recent abstract which was presented at APASL. This was held at Kyoto, Japan. There are more than 1,000 abstracts, as I understand, probably, and the book itself was 1,000 pages. And Mansa and Shantanu have done a great effort to find out only best of them and present around 30 abstracts over here today. Invite Dr. Shantanu first to present the abstracts, and then followed by Mansa. There will also be some sessions we have included, tried to include some basic science aspect also, to find out and do what we can do in our lab or do some research in our hospital also. Thank you.
Good afternoon, everyone. So today, as told by Dr. Anand, regarding basically the best of APASL 2024. It was a huge task for us. So this is basically APASL Kyoto. The conference was in Kyoto, but it was a huge 5-day conference, only particularly maintaining only a core subject of hepatology. So when you see of the best of APASL, there are almost a huge amount of posters, almost more than 1,000, with more than 1,000 orals, even including young investigator and plenary sessions, excluding the state of art lectures. So it was a huge task given to us, but finally, because of the time and this thing, so we made up to both clinical and basic sciences. I'll be more touching on clinical, and Dr. Mansa will be more touching on basic science aspect. So we'll be doing around 12 to 14 studies, which are most basically the randomized control studies, which are presented at APASL. So in short, I'll be dividing them in terms of cirrhosis, followed by ACLF, HCC, MAFLD, and hepatitis B. So the first RCT which I'm going to tell about is about the cirrhotic patients. So basically, we've been giving albumin in and out. So daily there are many recommendations based upon the albumin. There are strict guidelines which are definitely indicated, and relative indications were also there. So in this study, which they have given an oral talk, which showed that targeted and response guided albumin therapy, which improves the outcomes in ascites in cirrhosis patients rather than the previously given arbitrary value of almost 1 gram per kg body weight. So in this basically targetary, initially the previously thought targeting serum albumin above 4 should be the guidelines, but currently in this methodology, it was an open label randomized control trial. The patients were taken in albumin arm was receiving 20% albumin, targeting only serum albumin of 3 gram per deciliter rather than 4. And for first 2 weeks, they were given 60 grams per week, followed by 40 grams per week. And either a target of serum albumin more than 3 is taken as an endpoint, or an ascites control is taken as an endpoint, and a maximum duration of 12 months. So it was shown that there was a trend towards reduced mortality was also seen in patients who have received this albumin with this targeted values. The control of ascites was superior rather than the prefixed weekly ones which were giving albumin. So the control of ascites was superior, around 56 was compared to 30% in the standard arm. There was lower incidence of acute kidney injuries, 15% to 53% approximately, almost 1/3 the incidence of acute kidney injury, and even the infection rates are less. Also, biochemically, there's significant decline in the renal biomarkers, which is the cystatin C, IL-18, interleukin 18, and KIM-1, was observed in the albumin this arm, which was also slightly increased in the standard medical treatment arm. So it was proposed that targeting serum albumin around 3 is enough, with a lower incidence of AKD development or sepsis, and also has a better ascites control. So they concluded that the target should be around 3, but it should be response guided rather than a prefixed value. The second abstract is basically, it's a critical care related. It's a point of care ultrasound, focus monitoring and fluid resuscitation in cirrhosis with sepsis. It is from PGA Chandigarh. So they attributes that currently there are many studies which have been published that in patient with septic shock, in patients, what is the fluid, which is ideal fluid, whether it's 5% albumin or 20% albumin, whether it's crystalloids. So many trials have come in where it showed 5% albumin is superior. Then another trial which has come which showed that 20% albumin is superior to plasmolite. But this study shows basically they concentrate more upon the point of care cardiac ultrasound, So they have divided into 3 resuscitation strategies, which in the first 6 hours, which is the early 20% albumin, which is the first group. Second group is a balanced salt solution, which is the second group. And the third group is balanced salt solution in the first 3 hours and later on 20% albumin. So the focus was done within 3 hours of admission into the liver ICU. And it was continued with 1 day, 2 day, and 3 day. And the main target was to maintain a mean arterial pressure of 65 millimeter of mercury. So they also evaluated the predictors of circulatory failure and mortality using focus and serum biomarkers. So in this overall, the early albumin group, they have randomized 78 patients. Only balanced solutions, which are the crystalloids, is 65 patients. And in the third group, which is the balanced solutions, along with the late 20% albumin, were 37 patients. And CCM, which is a cirrhotic cardiac myopathy, was diagnosed in almost 78 patients, which is almost 40% in these patients. So this cirrhotic cardiomyopathy is been evaluated based upon the E prime velocity along with the left atrial velocity index, the volume index. So after doing a multivariate analysis, they have found that patients who have a higher E prime velocity, higher left atrial volume index, along with an elevated biomarker, specifically the endotoxins, NT-proBNP, galactin-3, and increased SOFA scores, are correlated well with the mortality, but not the type of fluid response. So basically, it's a presence of cirrhotic cardiomyopathy which predicts the patients developing whether they respond to the fluid intake, but not the type of fluid. Even the 28-day mortality did not differ in all the 3 groups, and they attribute it to the presence of cirrhotic cardiomyopathy in these patients, which can be evaluated at the admission level with the Doppler, with the 2D echo, and along with the biomarkers. So the third abstract was in the cirrhotic patient is basically the duration of vasoconstrictors. There are no specific guidelines and number of the duration of vasoconstrictor post EVL after the bleed. So after EVL, the initial following recommendations were only 3 to 5 days after endotherapy, but those guidelines were made with taking into consideration sclerotherapy, sclerotherapy as a standard of care. But later on, with the advent of EVL, there is no specific recommendation of number of days whether the vasoconstrictor have to be continued. So it was a network meta-analysis which was done. 9 studies were taken, total of 816 patients. Group 1, Group 2, Group 3, they have grouped based upon the number of days of vasoconstrictor used. Group 1 is 5 days, Group 2 is 2 to 3 days, and Group 3 is less than 24 hours. So there was no difference basically seen at the risk of rebleeding in all the groups, irrespective of number of days of vasoconstrictors. So basically, this is the scope where a randomized control trial based on the number of days can be considered in future to see whether number of days is significant, whether it is required, minimum number of days is required for the continuation of vasoconstrictors post-bleed. So this is from our hospital where they have seen the safety and efficacy of endoscopic glue versus US-guided glue plus coil in the treatment of gastric varices. But the primary outcome seen in this patient is the development of pulmonary embolism post the procedure. So the group A received glue and group B received US-guided coil and glue, and CT chest was performed in all the patients to detect pulmonary embolism in these patients. The primary outcome was the occurrence of pulmonary thromboembolism, and secondary outcomes were obliteration of varices and rebleed. Only 34% patients are enrolled out of 17 patients were enrolled in each group. 3 patients had pulmonary thromboembolism as per the CT and 1 in the US coil group. There was almost near complete occlusion, obliteration of varices in US group, almost 94%. The requirement of reintervention was comparatively less in the US group, and the rebleed rate, there was none in the US group who had rebled within the next 6 weeks. So US coil glue is much superior than only glue installation by endoscopy, and hence the further in future prospects, US should be taken as the standard of care for handling gastric varices. So another small abstract, which is the normal common thing, but after post-esophageal band ligation, whether you give sucralfate or PPA or combination, is there any benefit or any difference in all the 3? So it around 300 patients post-EVL or randomized, 100 each in 3 arms, and the randomization, after the randomization, the endoscopy was repeated after 14 days. The incidence of posterior ulcers has been seen. The posterior ulcer bleeding was occurring around only 9 patients overall in all the overall in 300 patients, 9 out of 300 patients, and there was no significant difference in post-tibial outcomes. So patients can be given sucralfate or PPR combination was the conclusion which is given by this abstract. So as we all know, the terlipressin is not indicated in USA currently. It's not FDA approved. Currently, after the confirmed trial, they have been given for HRS AKI, but as a bolus dose. So this abstract which I have published, this is from the US data. So which shows that continuous terlipressin infusion in HRS AKI in transplant enriched population, pre and post transplant patient developing AKI. So terlipressin can be safely given, and in these patients, specifically patients who have HRS AKI, they are taken, and these patients have received continuous terlipressin infusion, which we normally practice here. And ACLF grade 3, serum creatinine more than 5 and MELD more than 35 were excluded. So overall, almost 50%, 19 of 40 transplant underwent LT or SLKT by day 90, and there was improvement in creatinine and improvement in the renal functions. So terlipressin can be safely given as a continuous infusion. Even in the US population, probably they will be getting an FDA approval for even the continuous infusion later. So coming to, done with cirrhosis, coming to the ACLF. So ACLF in specifically the patients in alcoholic hepatitis related ACLF, which patient responds to steroids, who doesn't. So there are many studies which showed that the factors which predict the response of steroid response from pathological, from even the histopathological data to the clinical data. But whether it is dependent on severity of portal hypertension is never studied. So this studied almost ACLF alcoholic hepatitis patients past 2 years, around 74 patients have been analyzed who are responders basically. So who are responders, 42 patients were responders and 32 patients were non-responders. So the predictors of overall in the baseline were included are the AHHS score and the biopsy, the MELD score, ARC score, platelet count, and even HVPG more than 20.5 millimeter of mercury has predicted a steroid non-response with an almost area of under curve of 81. So this HVPG, which is more than 22.5, independently and significant predicted the mortality also in these patients who are non-responding to steroids. So even so, this has to be also taken into consideration regarding in patient non-responder. So we can accordingly plan for LT before giving a steroid trial. So it is an important determinant of suboptimal outcome in patient with alcoholic hepatitis ACLF. So this is also one of the common things in alcoholic hepatitis ACLF, where we normally give steroids for 4 weeks. So they have studied retrospectively the whether along with steroids, if you give antibiotic for 1 week versus antibiotic for 4 weeks, is there any difference? So oral antibiotics were given at discharge for 1 week versus 4 weeks have been studied. So overall, the primary objective was only to study the number of infections at day 28. Of all the patients who have received steroids, 110 patients who have received steroids, only 28 patients received cefixime for 4 weeks, while 82 patients received for only 7 days. So it was a retrospective data, and seeing this patient, taking consideration of this 28 versus 82, they have been seen that incidence of infection at 28 days and repeated hospitalization and mean hospitalization admission day were lower in patients who have received antibiotics for less than 4 weeks. So 4-week antibiotic plus steroid therapy had reduced the severity of infections and also the duration of hospitalization. So this is from our center, where we have done a double-blind RCT, where whether there's a role of rifaximin in patients with ACLF who are admitted to ICU with encephalopathy. So all patients who have come with overt hepatic encephalopathy with APASL-defined ACLF patients have been taken and have been randomized with to receive antibiotic plus rifaximin or antibiotic alone. The in-hospital mortality was significantly equal. There was no variation, there's no difference which was found in both the groups. Also, in the proportion of patient achieving infection resolution were comparable in both the groups, and it was shown that rifaximin has no added benefit in patients with ACLF who present with hepatic encephalopathy in admitted to ICU. Further, this new therapies which are coming, which is a DP mass therapy, where it is double plasma. It's called a double plasma molecular adsorption system. sometimes also used outside as cytokine filters, but other, so this even in the patient, this has been studied in patients with liver failure. So they have randomized 648 patients into DP mass group and also in the SMT group. So in the DP mass group, also only 32% had DP mass treatment alone, while 77 had DP mass followed by plasma exchange. They have seen the 28-day transplant-free mortality, and it was seen that it was lower in the DP mass group compared to patients who are only on standard medical treatment. So DP mass treatment for CLD can be considered as an extracorporeal therapy, which can significantly improve the liver function and 28-day mortality. So does the genetic interactions between the donor and recipient, will they affect the in changing the post-transplant diabetes outcome? So this is from Pennsylvania, from Raj Reddy sir group, which showed that post-transplant diabetes mellitus is linked with both the donor and the recipient. So there are polygenic risk scores for type 2 diabetes, insulin secretion and insulin sensitivity were calculated using observations available from almost large-scale genomic-wide associations. So out of the total, almost more than 1,000 recipient pairs which have been taken, for recipients who had the lowest type 2 diabetes genetic risk, donor livers with the highest type 2 diabetes PRS contributed to the development of post-transplant diabetic mellitus. So higher polygenic risk scores of donor can cause diabetes in the recipient post-transplant. So the recipient risk was also linked to factors associated with insulin secretion and beta cell function. So the whether if the recipient has the polygenic risk scores attributed to insulin secretion and beta cell function, they are attributed to have higher incidence of developing post-transplant diabetes mellitus. So it has also seen that, taking this consideration, donor liver contributed to the post-transplant diabetes mellitus via genes involved in the insulin sensitivity alone rather than insulin secretion. So for the donor, it's the genes which are for insulin sensitivity, and for the recipient, it's the insulin secretion, which affects and influence on the development of post-transplant diabetes mellitus. So other novel methods, so there are many methods they have been trying to attribute the non-invasive identification of patient with fibrosis in NASH patients. So what we use here is regularly is the fibroscan, but they also in China they have seeing the evidence of any exhaled nitric oxide as a non-invasive marker. So exhaled nitric oxide is because of the increased eNOS production in the endothelial nitric oxide synthesis production in patients with fibrosis and inflammation. So 147 patients with MASH were recruited, which are biopsy proven, and the diagnostic efficacy of eNOS has been seen. And also they have been validating this eNOS levels compared to other markers which are regularly available, which are the FAST, Agile 3-4 and FIB4 values, which determine the fibrosis. So the proportion of fibrotic MASH was only 30% in all the patients. The area under curve for eNOS was significantly higher compared to other markers such as FAST, Agile 3 and FIB4. There was a cutoff for ruling out fibrotic NASH and a cutoff for ruling in fibrotic NASH. So cutoff for eNOS more than 13.5 has higher specificity for ruling in fibrotic NASH. So this is one of the non-invasive marker which I've been trying to use for the detection of fibrosis in NASH patients. So whether when we see MRI we use regularly to see for any hepatic steatosis and based on PDFF fraction. So whether any 1.5 Tesla and 3 Tesla, is there any difference? So after this study, after they matched based upon the age, gender and body mass index, and based upon the PDFF value, they have seen that the patient that 1.5 Tesla is better for patients with high fat group and 3 Tesla is better for the low fat group. And further studies have to be validated based upon the type of MRI being used. So coming to the lean NASH, which is a lean MAFLD, which is currently being on rise. So whether there is an impact of single nucleotide polymorphisms on long-term prognosis in non-obese MAFLD. So it was a multi-center retrospective cohort study, and they were examined many SNPs such as PNPLA3, TM6SF2 and HHD. Out of the PNPLA3 also, they have seen that PNPL3 type GG has significantly higher incidence of development of lean NASH compared to CG and CC. So on long-term mortality, patients with PNPL3 GG in lean MAFLD patients have higher mortality compared to the patients who have PNPLA3 CC and CG. So one more current with the rise of PIVCA2. So with the whether PIVCA2, what is the diagnostic assessment of PIVCA2 in the detection of hepatocellular carcinoma in Indian patients? This is from ILBS. So they have taken AFP, PIVCA2 measured in 3 groups. So of HCC patient, and they have taken HCC patient, chronic liver disease patient, and even the normal controls, almost more than 100 patients each. So PIVCA2 demonstrated superior diagnostic performance, almost area under curve of 93%, 90.93 compared to AFP, which is only 90, and in the diagnosis of HCC. The combination of AFP and PIVCA improved the diagnostic performance. So they have proposed a model which is ASAP model, which have taken into biochemical markers such as AST, ALT along with AFP and PIVCA. So this model shows better accuracy than PIVCA2 alone in diagnosing a HCC and differentiating HCC from CLD. Also, they have shown a cutoff values of AFP, PIVCA, and AFP more than 7.56 and PIVCA more than 49 taken for the detection of HCC. So it is coming as a promising biomarker for diagnosis of HCC, more reliable than AFP as per the study. So these are some certain small studies. In short, I'll be going that patients post-stage hepatic decompensation in intermediate stage HCC. Currently, CTP has been taken as a guideline with CTP A and B. Higher CTP score, higher chance of post-stage decompensation. But this study from Mumbai, which showed that ALB score is considerably superior compared to CTP alone. And ALB score is a significant predictor of post-stage hepatic decompensation in patients with intermediate HCC undergoing TACE. So other in chronic hepatitis B, few RCTs have been used whether any effect of vitamin D and calcium on bones in chronic hepatitis who are receiving TDF. So TDF is prone to cause loss of bone mineral density as in a long-term follow-up. So patients receiving vitamin D and calcium together, it's an open label randomized trial, and they have seen in 32 patients in each group for 48 weeks. The bone mineral density has been considerably, the loss is considerably less in patients who receive vitamin D and calcium supplementation rather than patients who are not receiving the supplementation along with TDF. So this in patients with hepatitis B ACLF, thymosin alpha 1, which is a derivative of thymus gland, this if supplemented along with the normal treatment, it has shown that the patients who received thymosin alpha 1 in the experimental group had much better outcomes than compared to the patients who were having continuous only on standard medical treatment. And coming to the last, which randomized control trial, which has seen that 8-week tenofovir alafenamide to prevent perinatal transmission of hepatitis B virus, which is seen in China. Currently, TAF is not recommended. Currently, TDF is going on in Indian scenario, but they have seen that patients who receive TAF, that is in the third trimester, from 33 weeks gestational weeks to delivery date, or to the postpartum post 1 month, were randomly allocated receiving TAF. And it has been seen that at the delivery, almost equivalent in both the groups. In both the groups, there were no patients who had no infants who had acquired hepatitis B, and there were no side effects. So they were comparatively TAF can be considered as a peripartum treatment for patients in mothers who have hepatitis B. That's it. Thank you. So any specific questions of anything?
Patients who were included?
So target MELD, I'm not sure, but in detail there was only the abstracts which are there. Yeah.
We commonly use albumin we give for the patients, but we never target albumin as such, but we give only for 3 to 6 weeks.
3 to 6 weeks.
6 months is little difficult for us. You said about EVL and PPI. Most of us you PPI and sucralfate. Interesting study. And is there any non-invasive markers of alcoholic hepatitis? You said HUPG more than 20 is required.
22, yeah, 22.5 for non-responsive of steroid.
But is there a non-invasive marker at HUPG? We don't even do in most of the
Normal scenario we won't do, but non-invasive. But other studies also, it's most of pathological. If the AHHS score which are there and other histological markers predicted more, but no clinical markers which had showed response.
Most interesting study was post-transplant diabetes. Polygenic risk score, you said it predicts the development of diabetes. What are the components of polygenic risk score? Is there a genetics of that? Or
no, based upon the genome-wide association which they have done. So based on those, they have taken certain genes which are attributed to development of diabetes.
They have mentioned the genes and
in the abstract they haven't mentioned. Okay. So further into the details.
It's interesting for us to do actually polygenic risk score for diabetes.
Yeah, if the donor, few genes, if in the donor, if they have that particular genes, even though recipient is non-diabetic, the chances of recipient getting post-transplant diabetes are high.
So that means the liver was already sort of affected. They are all cadaver transplants.
Yeah, so cadaver, this is the US study which group they have done. So chances are there. So that all in that group also they have seen that having genes which have insulin sensitivity rather than insulin resistant, that's what insulin sensitivity, those genes are only particularly responsible for development of diabetes in recipient.
Something to look at.
No, in the abstract they haven't mentioned. Presentation is difficult. We could not attend everything.
We'll get that.
In the difference between the long-term usage of antibiotics and the short-term usage, there was one.
With alcoholic hepatitis, switch steroids.
No, antibiotics.
Yeah. Steroid plus antibiotic for 1 week and steroid plus antibiotic for 4 weeks.
So that in that you said the primary outcome is to see if there is any infection at the end of 28 days.
28 days.
Yeah. But what happened to those patients who died of sepsis or in between those?
The difference was not there, but how many who have died was not mentioned in the abstract. So there will be some persons who will be dying, but the difference in number of infection, number of death were not difference. The difference was lower. So who received 4 weeks had a much lower rate of infections.
These have actually been replicated multiple times from our study also, one in JAMA recently. The 4 studies currently, this is the 5th one. The antibiotics in alcoholic hepatitis. But we had some question on HCC.
PIVCA2. Already going on. We've already gone. 49. We have
but
all patients.
We are seeing patient 1000 and the patient doesn't have HCC. That is also Indian population.
That is Indian population.
They must
cartridge
like a HA370 or 330. But after the cartridge we used, we found that the ammonia level and the INR is worsening. INR is basically synthetic function are worsening. Only bilirubin part is improving.
So they are mainly in concern. They said that SOFA scores come down. More of SIRS components will come down. If it is mostly related to cytokine storm or hypercytokinemia and other things.
But the SOFA, if you will calculate the SOFA, there's 6 organs. Only the what organ they can be improved with is a LFT part.
So the LFT can be improved even if inflammation is affecting the kidney. Renal component can be increased. Heart rate will decrease. BP might stabilize. So all components come under SOFA.
Okay, but we never use cartridge because it's little costly. Bilirubin cartridge is costing roughly more than 1 lakh rupees.
But bilirubin cartridge and this mass is different, I guess. Both are different.
You said about POCUS, no? POCUS has to be done with 3 hours of ICU.
Within 3 hours of ICU admission.
Any ACL?
Any patient, any critically ill septic shock.
That is
no, but their focus is more of concentrating on cardiac component. They did not see of IVC or they have measured IVC, but they have seen more of cardiac component. How much is there? How much is the compliance? How much is the E prime velocity? E by E ratios, and then based upon that, the fluid administration.
We did one study where we are measuring everything, but little difficult to do. But now most of the people know that E by E and then everything. But now we have started like a TAPSE and MAPSE, which may tell the right heart failure, left heart failure also, because some patient on the cardiac strain on these kind of CLD patients, you can evaluate easily.
Correct. But interesting is that this study they said fluid is not any fluid you can give. It is irrespective of fluid. That is the important thing, because till now studies have come that septic shock, this is 5% albumin or plasmolate or 20% albumin, which showed superiority to the other. But this study is showing that irrespective of whatever the fluid, based upon the heart status, if you can increase the volume status, then patient will have equivalent outcomes.
So focus is the most important thing. Everybody is now talking about focus. There is a EASL workshop on focus this time at Milan. So to educate the hepatologist how to do a ultrasound and assess the liver and heart. And it is also being planned for ASLD again.
Yes.
It is a non-invasive.
It's a new stethoscope.
Multiple times repeated.
They say it's the new stethoscope.
Yeah, repeated. The fluid resistance is based on focus. Yeah.
Nitric oxide.
So they said that in any patient with inflammation, there will be endothelial dysfunction. So there will be eNOS activity, and the patients with increased endothelial nitric oxide synthesis will have increased nitric oxide production. Yeah, it was tested against FIB4, against Agile 3+. So in patients not with cirrhosis, but more with advanced fibrosis.
Thank you, Shantu.
Thanks.
Thank you very much, Dr. Mans. Thank you for taking so many questions, sir. Sorry for that.
Good afternoon, everyone. We had a good clinical round of abstracts from APASL. Mine will be focused mainly on basic sciences and genetics and the nutrition aspects of it. This is an overview of the abstracts presented from AIG at APASL. We had a total of 6 abstracts, and 2 of which are presented by Dr. Shantan, which is comparison of tenofovir, alafenamide, and entecavir therapy in patients with severe acute hepatitis B. And the second one was drug-resistant organism colonization in patients with cirrhosis who are admitted to ICU. And we had 3 other abstracts, which is hyperimmune bovine colostrum, role, safety and efficacy in steroid-ineligible severe alcoholic hepatitis ACLF patients. And rifaximin has no beneficial role in ACLF patients admitted to ICU. We discussed this earlier. And another demographic study on pediatric acute liver failure experience from a tertiary care center in India. Coming to the first abstract, interferon reduces HCC risk in high-risk Asian patients with chronic hepatitis B. This is from a center in China. The objective of the study was to demonstrate the efficacy of pegylated interferon and a nucleoside analog in reducing HCC risk in high-risk Asian patients with chronic Hep B. It's a multi-center prospective study starting in October 2020, and the methodology was to assess after completion of treatment at 48 weeks, and various scores were analyzed for HCC risk. And this is a baseline HCC risk. They have categorized into low risk, intermediate, and high risk based on the scores from patients receiving interferon and the nuke. In the interferon were a total of 8,000 patients. It had a higher number of low risk patients, that is 52%, whereas high risk patients were higher in the nuke category, which is 18% compared to 7.5 in pegylated interferon. And interestingly, after treatment, after the end of 48 weeks, the patients from high risk transforming to intermediate risk was higher in interferon therapy compared to nucleoside, nuke group, which is only 14%. And the incidence of HCC at 1 year was 0.3% in interferon group, which is low risk. That is, HCC incidence is low in high risk group and others at baseline. Coming to the nuke category, the high HCC incidence was observed in high risk population. That is, if you're, according to the abstract, if the patient is categorized as high risk at baseline, there is a very high risk of HCC in patients receiving nuke compared to those who are receiving interferon. And they've concluded that antiviral treatments reduce the HCC risk in HCC patients, and interferon-based therapy seems to be superior in that aspect. And another study where genetic features of patients with Wilson's disease in the Republic of Moldova, which is a pilot study. Wilson's disease, being a rare metabolic disease, is an autosomal recessive disorder, and we all know the importance of genetic analysis in this category. The objective was to assess the epidemiological characteristics and genetic features of the Moldovan patients with Wilson's disease. It's a retrospective study. Total of 108 patients were included between 2006 and 23, and Leipzig scoring system was used. Total of 108, 57.4% were males, and the mean age was 16 years, and all of them were 79% were Moldovan origin, and all of them were Caucasian, and no history of consanguineous marriage in the family. And the results showed that there was a hepatic onset presentation in 45% of women, and neurological presentation was more common in men, and that was seen in 61%. And it was statistically significant in both the groups. In this study, genetic testing has been done, and 61.3% mutation was found to be detected out of the patients who were baseline Wilson's and who underwent genetic testing. And out of the mutation detected, 70% was found to be pathogenic variants, and the most frequent mutation which was noticed was PH1069Q. Which was seen in 62.1% of the patient. And out of this mutation which was detected, 36.1 was homozygous recessive, and other variants were seen in 41.7%. And the second mutation was found to be unknown in 22%, and 52.8% of cases, this mutation, the one this is detected in this study, was found to be associated with liver damage. And they've concluded that this mutation, that is PH1069Q, represents the most frequent pathogenic variant identified in this population, and hepatic presentation has been identified at a younger age, and neuropsychiatric manifestations are most commonly seen at the older age of presentation. Coming to the next study, which is an RCT evaluating the efficacy of saroglitazar versus obeticholic acid in patients with MAFLD and MASH. As we know, these are the most commonly used drugs. The aim is to explore the efficacy of OCA in patients with MAFLD or MASH. It's a prospective study. They've used obeticholic acid at dosage of 10 mg and saro of 4 mg in 50 patients each. And they analyzed for the change in primary outcomes, that is LSM and CAP at baseline and at 24 weeks using fibroscan and various other parameters. And they found that at the end of 24 weeks, reduction in LSM was seen in 20% in the OCA group, whereas it is seen in 23% in the SARO group. That is, there is not approximately 20% reduction at the end of 24 weeks duration, and no significant difference between both the categories. However, the reduction in CAP, that is coming to the steatosis, it is seen in 21% in those who received OCA, whereas only 10% in those who received SARO. More reduction in CAP in the OCA group from this study in those who received OCA in the steatosis thing. And they have concluded that OCA has a comparable effect with saroglitazar in reducing fibrosis and triglycerides, and however has an edge over saroglitazar in reducing steatosis. Coming to the next study from China, where metabolic reprogramming of CD4 1+ T cells by mesenchymal stem cell derived extracellular vesicles attenuates AIH through mitochondrial transfer. Coming to the introduction, AIH being a severe liver disease, it is characterized by various immune disorders, which is including abnormal T cell activation, and efficient therapies, which is targeting this cascade, was urgently needed. And the metabolic features of CD4+ T cells in AIH and the corresponding targeted therapies have not been well explored, and hence this study was planned. In this study, CD4+ T cells of AIH patients were isolated from the peripheral blood, and the level of key enzymes related to glycolysis was measured, and the liver biopsy specimens were stained with CD4 and GLUT1, and 2 DG or mesenchymal stem cell derived extracellular vesicles. They were injected into the AIH mice and to evaluate the therapeutic effects. RNA sequencing was used to identify the gene profile changes in these CD4+ T cells subjected to MSC EVs, MSC extracellular vesicles. And they found that enhanced glycolysis of CD4 plus T cells is a key factor in patients with AIH patients and also mice. And on undergoing this MSc EV treatment, it induced a metabolic switch which has enhanced the glycolysis to mitochondrial oxidative glycophosphorylation, and this has ameliorated liver damage. And further, it has decreased the CD4 T cell activation, and hence this probably could guide us in further treatment modalities in future. And they have concluded that MSc EVs can metabolically reprogram T cell phenotype by transferring the mitochondrial components, which can offer a new avenue for treating autoimmune diseases. Next, coming to PBC, a worse subgroup of PBC from China, where they have analyzed patients with jaundice and ductopenia on liver biopsy. The objective of the study is to see hyperbilirubinemia associated with poor prognosis of PSC, as we know, while not all patients with ductopenia present with prolonged jaundice. It is a retrospective study, recruited patients with ductopenia. They have analyzed various demographic and clinico-pathological data and treatment response, and BSEP and MRP2 staining has also been done. A total of 265 patients who underwent liver biopsy with PBC, out of which 77 had ductopenia, and 18 patients were jaundiced and 59 were not jaundiced. So out of the patients who were ductopenic, majority were not jaundiced. But out of the patients who had jaundice, they were found to have higher levels of bilirubin, bile acids, cholesterol and triglycerides. Although they had similar levels of enzymes compared to patients with no jaundice, the patients with jaundice were also found to have a lower survival rate, but there was no difference in response to UDCA in both the groups. But however, patients who did not have jaundice also had expression of BSEP and MRP2. They concluded that jaundice does not seem to follow the same course as ductopenia in PBC, and ductopenic patients with PBC showed a similar worse treatment response and poor prognosis and uncompensated bile salt transporter. So basically, patients who are ductopenic and jaundice have a poorer survival, but however, no difference in response to UDCA has been noted in both the groups. Compared to the next study, where efficacy of magnesium isoglyceryl MGIG, that is isoglycerisinate, has been compared to steroids in liver injury after novel anti-neoplastic therapy. As we all know, after the novel advent of immunotherapy, post-immune-mediated hepatitis is a common reaction noted in many patients. And liver injury has been commonly been treated with steroids. In this category, they have explored the role of this MGIG in comparison to steroids in this subgroup of patients. So they've conducted a retrospective multi-center study. MGIG versus steroids has been studied in both the groups, and a propensity score matching has been done. A total of 900 patients, and two populations have been studied in this in a ratio of 1:1 and 2:1. In the first population, they have compared MGIG versus steroids, and in the second group, they have compared MGIG plus steroids with supportive care versus steroids and supportive care, what we normally do. So in the category where MGIG with steroids was compared, in those population who received only MGIG, there is a higher 50% reduction in total bilirubin at 7 days compared to those who received steroids alone. And in the category who received the combination therapy, that is including steroids and the MGIG with supportive care, there was a higher normalization of AST and ALT, and also a higher 50% reduction rate of various other comparative markers at day 7. And they concluded that MGIG may aid to improve recovery as well as act as an add-on therapy to glucocorticoids and supportive care in patients with this immune-mediated hepatitis. Coming to the next study, sequential use of LSM and Agile-4 for assessing cirrhosis. This is an Indian study from PGI. Despite the LSM is being commonly used to identify steatosis and fibrosis, it has a relative low specificity and it is more suited to rule out cirrhosis. And Agile-4 is a novel score. It's an LSM-based score which is designed to have high specificity for detecting cirrhosis in those patients who have a reduced gray zone. With a reduced gray zone. This is a multi-center. This is an ongoing trial. 42 centers have been included in India. out of which currently 381 patients, that is 63%, had liver biopsy. They have been analyzed and they have taken an LSM less than 3 to rule out cirrhosis and more than 16.1 as to rule in cirrhosis. And for Agile 4, they've taken a cutoff of less than 0.251 to rule out and more than 0.5 to rule in cirrhosis. And AUROC was found to be similar in both the groups, and Agile 4 had a higher specificity to rule in cirrhosis with 94.7%, and LSM to rule out cirrhosis, it has a higher sensitivity of 84%. Although it is higher, it is an acceptable value, which is 84. And the gray zone was higher with LSM compared to Agile 4. Gray zone was seen in 34.9% and only 14% in Agile 4. So by using FibroScan, that is LSM guided values, the patients with gray zone, where we cannot rule in nor rule out, is higher in LSM compared to Agile 4. They have also used a combined sequential approach where they have done LSM followed by Agile 4. And in this, the sensitivity has to rule out cirrhosis is 81% and to rule in the specificity is 95%. And hence they have concluded that the sequential use of LSM followed by Agile, that is a combination therapy, has optimized the use of this FibroScan and has a better usage as a point of care tool to assess cirrhosis. This is another study from PGI Chandigarh where assessing the outpatient intensive nutrition therapy to improve survival and frailty in ACLF. As we all know, there is an utmost importance for nutrition in patients with ACLF, and the therapies available currently are limited. And they have enrolled 70 patients with APASL ACLF definition. Frailty has been assessed by liver frailty index at baseline. Patients have been randomized 1:1 to medical therapy versus outpatient intensive nutrition therapy and along with standard medical treatment alone. The primary outcome is to assess the improvement in survival at 3 months, and the secondary outcomes was to see the improvement in frailty, various prognostic scores, and also hospitalization. And they found that the survival at 3 months was higher in patients who received intensive nutrition therapy versus those who received standard medical treatment alone. And the liver frailty index, the changes were higher in those who received nutritional therapy. This is a delta score. The change has been higher in this group compared to the SMT group. And the 3-month hospitalizations were also much lower in those patients who received the nutritional therapy. And on further regression analysis, they found that the predictors of mortality in frailty included allocation to group, that is likely the nutritional therapy, and the ARC score were independent predictors. And the survival predictors was also arm allocation, ARC score, and the baseline skeletal muscle index. But however, in the given abstract, they have not mentioned what is the regimen used for this outpatient intensive nutrition therapy. It is only mentioned as dietitian prescribed. So this will need further analysis. This is another study from ILBS, which studied high serum bile acid will drive AKI progression and terlipressin non-response in patients with ACLF. So what are the predictors of non-response to terlipressin in patients with AKI ACLF? It's a prospective cohort of ACLF patients, that is 242, have been taken. Serum bile acids and urine NGAL were measured at enrollment, and AKI predictors were identified using various logistic regression. The mean age of the patient was 43, predominantly males, and sepsis was seen in 87%. And these are the AKIs, 40% in AKI stage 1, stage 2 is 31, and stage 3 is 29%. HRS AKI was found in 61%. Mean serum bile acids was higher, that is 154, and NGAL was also significantly higher, that is 1881. And AKI progression at day 4 on giving terlipressin was seen in 42%, that is almost half the patients, and dialysis requirement was seen in 1/4 of the patients, that is 26%. So these are the patients on terlipressin with about 87% with sepsis and with high bile acids and NGAL with progression and dialysis. So they found that on multivariate analysis, higher bile acid score at baseline, high ARC score, NGAL, and the number of organ failures predicted AKI progression, and it is also an independent predictor of mortality. And they've concluded that serum bile acid correlates with circulatory failure and predicts AKI progression and non-response in HRS AKI, but not mortality. And high serum bile acids, that is 175 as a cutoff, NGAL and the presence of bile acids could signify structural AKI and limited response to vasoconstrictors. And hence it will help us in prognosticating the patients and also evaluating other modalities of treatment. Thank you.
Genetics positive, only 60%. That is also similar. The findings are similar, but not this gene. We haven't found this one. I don't remember the number.
And
It's one just-
069 hours.
It's a common mutation reported for Wilson's. It's very well known in European ancestry. But in our population, it is completely different, and it is similar to the ones which have been found in Calcutta and TMC.
Gene or
Most of the germline variants they don't have. These are passed on from the parents. Somatic, yes.
Difficult to identify.
Right.
Usually don't. Siblings, if they have disease as well. They have only mutation and
In case we find the family, way to explain that expressivity. So that's what the typical genetics explains, that probably there's incomplete penetrance of the variant in the family or in the population. But the other thing we conveniently miss is, more often than not, we are looking at the disease causing variants but not the protective variants. Because most of the case control studies look at the disease causing variants, not the other way around.
obetipolic acid reduced steatosis. Very unusual actually compared to saroglitazar. Also, this is a very novel study. As of now, it is not approved, obetipolic acid.
Yes,
for NASH.
but they've shown good reduction in LSM.
Fat compared to.
Yeah.
Was it because of weight loss? Have they measured
They've not mentioned about the other modalities used, or
reduction or something?
baseline BMI also not given.
Most
Sir.
of these patients, when they take high dose, they lose weight. High bilirubin levels is predictive of non-response, that we know.
But
see
high-
only bilirubin.
No, but because of colemic nephropathy, risk will be higher if the bile acids are on the higher side. They have not given a comparison between patients with who had normal bile acids was not given. The mean, but they've given a cutoff. A cutoff of 175 has been taken as a poor progression, poor response to terlipressin. Although it is high, even more than 20 is considered high bile acids. But if it is probably less than 20 to 175, better response. But more than 175, poor response to terlipressin.
For us, more than 10, we actually use only bile acid levels in ICP, in NC. Other than that, we usually don't measure bile acid at all.
It is mostly a research tool.
Often, pregnancy, if it is more than 10, we say it's high risk. More than 40 is high risk.
ICP.
Perinatal model.
I just want to give. We are now approved to manufacture placenta-derived MSCs. We are now culturing MSCs from the placenta. We are able to isolate. So that secretome data we have. MSC secretome data given to rats in our place we have.
So if you want to make any study, we will be able to. Them for research. Was studied with secretome. So problem is, see, with regulations are years together. If we can give the secretome as such, that's an easy way to avoid the cell. If you want to isolate EVs, we will be able to. Ultrasound.
Thank you.